for this one, I'm wondering if, yeah, okay, I'll talk through it and then maybe examples after. But if you do have a burning question, I don't mind if you interrupt me. So let's look a little bit more about the practice of the Health in All Policies approach. I'm going to go through in a bit more detail the framework for practice, which was developed and agreed on by countries in the World Health Assembly in 2015. So all of this is quite recent. Then I'm going to go through some packages of astuces, as we say in French, from the practice. And I'll tell you when I get there how that was developed. And then I'll go to 2 cases, and I'll wrap up with a summary. So first of all, I mentioned earlier that we have the situation of the conditions affecting health, which we have very good evidence on. We have then the link between the policies that are made and then the conditions that they're resulting, and we're assuming that there's some link between the transport sector policies and the results we're getting for transport. I would imagine there is a very strong link. And then finally, we say, well, if all of that is not generating the conditions that we would like to see, with everyone having a fair chance for life expectancy that is equitable, well, how do we influence it? So to come back to that question, it is difficult. As one of our colleagues here mentioned, he named the one difficulty about having a very multi-layered government or very democratic government with many entities involved. Another issue is that it is multi-determinate. So if someone is living in poor housing, they often have poor jobs, they often have living in a neighborhood that is not good, etc. So there is complexity around which are the policies maybe coming together in a particular neighborhood. It's difficult because there are a number of government agencies, which was the point that was raised earlier on. So it is difficult, and you're requiring them to work. They're already working together within some way, but now you're looking for them to do something a bit different, in the sense that you're wanting them to create space to explore what they could do better. So such joined-up governance is also a challenge, because you're requiring not only the administration, but you're also requiring the leadership, the politicians, to look at mechanisms for joining up the policy so that your policy on economic prosperity and employment are not contradictory, as well as tourism, as well as the environment, and so on. And then finally, it's not only just about the government, it's also about the institutions that lobby the government, the institutions who are stakeholders, that work with the government on the implementation of policies in different sectors. So it's complex. And the policies in their silos, we call them traditionally siloed policy making, do deliver a lot of development and well-being that we experience in society. We have good roads. If we are lucky, we have clean water. So that it is a challenge, but the final challenge, I would say, is that the silos are used to working in a certain way, so having to work differently is a challenge. But also underpinning all of this are the interests behind the different policy agendas and the wealth, really, that those interests can make from a policy being one way or another. So who are the stakeholders? And final point is obviously that the population health, who advocates for fairness in population health? Who advocates for fairness, environmental sustainability? It's hard to attribute the cost to one particular sector or person. It's actually a public good. And with public goods, we know from economic theory that you actually need public sector involvement to ensure a fair distribution and to ensure that public goods actually happen. So the framework I mentioned earlier is shown again here. I'm not going to read through that again, but instead I'm going to go through what is under each of those components. So if we're doing a health in all policies approach, what do we do for capacity building? We support institutional development and participate in community capacity building so that people and the voters in different communities understand the links between the conditions they're living in and their health. And this can be done through consumer magazines. I know I subscribe to one whose name I've forgotten, but it tells you what products on the market, what impacts, have they been tested for health, and so on. So it can be very practical in terms of establishing the conditions in the society to understand the links between the policies and the kind of environment they're living in, and ultimately their health and their family's health. In capacity building, you would train a skilled workforce. With competencies to analyze the policies in other sectors and look for potential health implications across sectors. If no one in your government is doing that, or in your institution is doing that, then you won't know what are the negative impacts. You might hear about it afterwards. So you need, for the health sector, to be proactive in looking at the potential health implications. Public health capacities need to be there to monitor public health and its determinants along the lines of some of those visuals I showed in the previous presentation. So you need data, and you need data analyses that not only coming from your administrative data in the hospitals, but also from living surveys, community surveys, and so on. Establish the need and priorities for health in all policies. Well, you need to really look at what are common concerns and co-benefits, and then where are the conflicts of interests. So you need to have a way of evaluating this, because there's no point trying to push a transport agenda which you know is going to be good for health, but it's not practical in terms of the goals that the transport sector is accountable for, or in terms of the investments they've made in public vehicles and so on, the buses, or the contracts they have with the private bus and train companies, and so on. So the health and all policies approach says understand where there are potentials, what are the concerns, and where are the opportunities for action. So it's about taking the policy process, and here you are in health and all policies, trying to look for areas where you can influence so that the conditions can change. The action that's done needs to be framed, but it can only be framed properly if there's an understanding of what the overall priorities are for the government and for other sectors. And this will determine, again, the scope of the policies that have potentially important implications for health and also for the health system functioning. As I mentioned, the conditions in society also impact the functioning and costs of the healthcare system and the efficacy. In the health in all policies approach, you need to make use of existing or create new, if they don't exist, structures for multi-sectoral action. It won't just happen. People will need an opportunity, a monthly meeting, a website, a way of coming together, some guidance materials on how to think, maybe jointly analyze some of their policies to identify opportunities. And there has to be political will, and there have to be accountability mechanisms. If people are using time to do this work as part of their job, they need to be accountable for what influence, what effect they've managed to have on the policies in other sectors. What have been some of the other benefits that have come out of this? Eventually, we would like to see, with good public health reporting, you would be able to track better the changes in the policies to changes then in some indicators for health. But this hasn't been done extensively yet. Then you need to have a function whereby you facilitate assessment and engagement of all sectors in the community and the use of impact assessments. So impact assessment, human impact assessment, integrated impact assessment, environmental impact assessment, they all have a health component, strategic impact assessment. And the use of these tools is a source of both information, but also a way to ensure engagement of other sectors. Sometimes the impact assessment is underpinned by legislation, but often it's not. So it requires willing parties in the different parts of government to undertake it. And finally, the last point is around the monitoring, evaluation, and reporting. And right now in the world, if we looked about 2 or 3 years ago, we looked at what national reporting was done for health. And there are very little routine national reports that describe the conditions for health in a country and describe how the conditions may have changed that are affecting health. And that's, for me, is a little bit astounding, and it's sort of to the detriment of my own sector in a way, or our own sector if if I'm speaking only to health people. But there is no routine reporting in 90% of countries. We managed to find 16 that have some kind of routine report. Italy, Canada, there were just a few. And they hadn't been, maybe, and our criteria was very low, that they should just report at least on 4 aspects of the conditions for health, something on just a minimal aspects. Maybe forget what the 4 were, but they were simple things like tobacco, if they're reporting about tobacco smoking, and also reporting on food, unhealthy food, and so on. So it wasn't a very high criteria, and maybe 1 environmental indicator. So there is some way to go, and unless we consciously try to build up a system for health in all policies, it won't just happen, because there is no private interest in this field. It is an area for public interest. So the 2 cases I show you will be the 2 longest, well, 2 of the longest running. Before I move to my 2 cases, sorry. The second part of my presentation is now going to just take you through a few astuces that have been gathered, and there were 3 points in time at which this was gathered. This first slide shows you a declaration that was made in 2010, which for us at WHO was really the start of our work on health in all policies. At a meeting where people interested in this topic came, and they talked about what kind of health sector leadership qualities do we need to start developing within the health sector in order to support health in all policies approaches. And for me, this list I've used now for 10 years, and it hasn't lost its relevance as the field has developed and more information has been found. I feel this list is very comprehensive. I'm not going to read it all. Is that okay? I'll just give you 30 seconds just to read. But for me, it's both relevant and quite practical. If you were organizing a health and all policies approach and a unit or initiative in your office, you would start to know what you had to look to do. What functions. A second piece of work, this was later on, there was a book produced with case studies. There were 13 case studies produced from about 2015 to 2017. So it covered 13 examples, including Shandong in China, Quito in Ecuador, Wales, Quebec, South Australia, Finland, and another for Zambia, Namibia, Suriname, California. And in that study, we looked at some of the advice to countries on how do you initiate, how do you implement, and how do you sustain. And so just to take, I'm going to take two examples because we'll talk about them later. In South Australia, there was a special program held that was a collaborative program between the education sector and the health sector to have a thinker in residence, which would be an international expert who would come for a period of time to live in South Australia and to engage in academic research, speaking with policymakers to explore how could you make a better South Australia? How could you create a South Australia that was very ahead of the rest of the world in terms of the way it approached health and well-being? And that was a critical point because at that point people were working in the government trying to start a health in all policies approach, and they met with the person who was the thinker in residence, and together they managed to forge the start of the Health in All Policies program in the state of South Australia. And that program is still running today, and there are a number of new states across Australia who are starting to be drawn into a network for sharing the different approaches that are being taken for this issue in Australia as a whole. Then in California, the initiation of the Californian experience was around 2009-10, at the time that Arnold Schwarzenegger was governor. And at that stage, the climate and the environment was a big passion for the governor. And then obesity was also highlighted as a major issue for the population in California. And with that, there was again a group in public health that had been working on this idea of systems change and how to introduce a health and all policies function. And they took that opportunity. In the implementation phase, the South Australians developed a central commitment with their an overarching memorandum with their central government, and I'll explain that more later. In California, there was actually an executive order by the governor that established the task force. So in actually implementing a unit or a function that would follow up on the health and all policies approach, these were some of the administrative executive mechanisms used. In Quebec, it's supported by a council of ministers. And then in terms of sustaining, this is more looking at it from a longer period. We haven't mentioned much on Thailand, but Thailand has also been working on this for about 10 or 12 years. In Wales, you have the Wellbeing Futures Act. In Thailand, they have the National Health Act. In Australia, the Public Health Act. So the eventual legislative part of this work becomes quite important. All these countries say it has been very important in terms of them being able to carry on for 10 years in this field. There was an ordinance in the metropole in Quito, and there was a policy on prevention which was important to sustain the work in Quebec. Finally, I'm going to turn to a survey that was done. This is the most recent information we have on the practice from 22 different countries, and the countries were asked to self-identify themselves. And this is how, the first time we've tried to, the field has tried to grade health in all policies in terms of some maturity scale. So in the maturity scale, you've got emerging, progressing, and established. And in the questions, if you can read them, the emerging refers to groups that are interested but haven't sought approval in their particular jurisdiction. The survey uses the word jurisdiction to mean it could be local, it could be state, it could be canton, it could be federal, etc. It could mean, progressing means that there is a formal commitment through maybe a memorandum of understanding or some formal policy. And then the maturity is established if you've actually a formal mechanism and health and all policies is mandatory, that there's some in working in government. Now, not many countries are in the established aspect, but there are a lot of countries who are working at the phase of maturity of emerging or progressing. From the study of the 42 jurisdictions, some key points were again recaptured regarding the importance of governance, that the majority of the respondents said they had some level of governance arrangements or some sort of formalized structure, and that this was important. And the three sets of graphs you see there refer to the cluster of emerging countries, progressing and established, or emerging jurisdictions, I should say, progressing and established. And this is really about looking at the importance of having a formal governance mechanism to support the leadership that is needed for health in all policies, because this new role that the health sector has to take is quite surprising for people in other parts of government, because they don't expect health to be coming to them with health issues. They see health as something more about repair and health care, and not so much about prevention and promotion. So both the governance and leadership having a formal mechanism and structures were both important for overseeing it, but also for the implementation. I've just toggled between the two slides because it's the same issue of governance and finance, governance and leadership structures being important, both for overseeing and accountability, but also for implementing. If you don't know who to speak to in the other sector, or if that person isn't authorized, it becomes trying to work across the silos, it's impossible. It's difficult as it is. The other conditions for success that the survey highlighted related to resources. You need to have a dedicated people, 2-3 people at least, who are paying attention to this in a particular jurisdiction. The entry points and ways of working can be very different depending on the context. And this again refers also to the governance context, the democratic context, the way the administration is organized, and so on. Health diplomacy and negotiation skills were seen as critical capabilities. So if you're hiring a person to start a health and all policies unit, you would want to look for people who could fulfill some of these skills. Monitoring, evaluating, and reporting was considered by the groups working on this as complex, important, but likely to occur later on. So not to have to show your impact on policies within the first year of initiating would be a bit too ambitious, because you have to have time to build the relationships with the other sectors, ensure there's an authorizing environment for the work, and then take time to prioritize and understand each other's, in particular the other sectors' targets and goals, and where are their real opportunities. And establishing the priorities is time-consuming, but it was very important in ensuring a good strategic direction, and then also being able to then have an outcome which can be evaluated or reported on at a later stage in order to reinforce the political commitment to this way of working, and the organization's commitment, really, the manager's commitment. So in South Australia, I'm now moving from the general astuce, or the general advice, which came through these more collected pieces of work, just to give you a quick snapshot of two. The California one's a bit longer. In South Australia, which is the state that you see in the picture there, they've developed, this is their model, but so in their health in all policies mechanisms, they've got, or in their approach, I should say, they have a governance aspect, which gives them a central government mandate through a formal agreement between the central department and the health department. They also have public health legislation to support systematically doing high up across government, although the legislation only came halfway through their process. Their process was quite instrumental in supporting the legislation, because they ended up with very good relationships with a lot of ministries who will then not threatened through the establishment of the legislation. If tomorrow you go to your colleagues in energy and in transport, and you say, we're going to have public health legislation and impact assessment on everything you do, I'm sure you wouldn't get your legislation passed. So that was not necessarily something you start off with. They then, under their governance, they also have strategic priorities that are for the state a priority, and which all the different areas of government have to report on their progress towards these priorities. So that provides at least a priority framework. The most interesting aspect of the South Australia case, which they started with, was in fact the central part, practice and process. That is how they started. They started with engage, have coffee, meet, understand, gather what is the other sector's perspective, then gather the evidence that's needed. If the other sector's working on grey water, indigenous motor car licenses, if they're working on subsidized housing, whatever it is, help the other sector through looking at what policy options they're considering and which could be best for health and well-being. Generate then together the solutions, and then don't leave it like that. Don't leave the other sector to deal with housing alone and trying to get a new policy in place or an increased budget. But help them to navigate the solution to its conclusion. And then evaluate, which is evaluate as part of the policy cycle, but also evaluate in terms of what you've learned from the health and all policies experience and how this can change your practice and process for the next group or issue that you may work on. And then in the outcomes, they've said there are two types of outcomes, the short term and the long term. And in the short term, the impacts will be measured around developing capacity across the system to receive information on the social conditions and their impact on health, increase understanding and the action on the determinants of health, and improve the networks of collaboration. And all of those outcomes could be measured in a short enough time, three years or so. The long term, they wanted strengthened public policy outcomes. So they really wanted to see the impact of, I come back to housing, impact of the housing policy on homelessness. That is a longer term outcome. And then ultimately on substance abuse or addictions, which are associated with homelessness. Improved population health, well-being, and equity is a longer-term goal. So changes in the life expectancy would be longer term. They also had the principles shown at the bottom, which I'll highlight in a separate slide later. This is this is just to show the type of governance arrangements they had. They had cross-government, or they have cross-government policy teams. They have executive oversight from the directors in the different departments. Then the senior chief executives who manage the different portfolios of government, the legislation, and the memorandum of understanding between central government and health. They've also done some evaluations. I'm not going to ask you to read this, but it's in line with the question that the moderator asked about evaluation. And they had a grant from the Australian National Medical Sciences, their highest medical science and research body, funding body. And it was quite unusual to give a grant, but they wrote a very good proposal with some academics in Adelaide, and they developed a 2 to 3 year or maybe longer evaluation program. And some of the results of this program have been published using this model. I mentioned the principles were very important in Australia. In fact, in the health and all policies area of work, they are very much advocating for the principles of communication and networking, leadership, experiential learning, so having the bureaucracies and your administrative structures allow for experiential learning, advocacy, having shared resources, flexibility and responsiveness to partners from other sectors, and mutual recognition and respect. Not to say, because we're medical, we're better, our evidence is better. No, to respect the evidence as it comes through in different disciplines where, who populate other policy portfolios. So the evidence from engineering or town planning will be quite different from the evidence that public health is used to. They also have been, at the moment, they're working on trust, to understand the role of trust across government officials and how this plays a role. They've done a survey on this, looking at between 2013 and 2015, asking how is trust created with joined-up government relationships, how is trust maintained, and how can it be lost, and what happens when it's lost. This is kind of a summary slide taken from the article where they published their results. But they identify factors that build trust, like the skills and capabilities of individuals, really being able to communicate how the conditions of health are affecting the health of the population and why it's important to work on policies in other sectors. Faith in the power of the governance systems, so the mandate that they have must be secure so that people do not feel like they won't be given credit for working with the health sector on these issues. Demonstrated or envisaged co-benefits are very important. If the non-health or the person working in the other agency doesn't see a benefit for their agenda, that doesn't build trust, it builds mistrust. The transparency of the approach is important, and the own or the other person's positive experience will reinforce trust. Maintaining trust, you need a lot of the principles that were mentioned earlier: regular communication, sharing of credit, empathy, flexibility, and make sure you're achieving the goals that you're setting. And then the threats to trust come around a hostile bureaucratic environment. If you don't have support to work together, and if there's hostility between your manager and another sector's manager, it's not going to produce trust, and trust is important for maintaining the health in all policies intersectoral work. The fluctuation of government resources and priorities, which really emphasizes the important role of having some core resources to work on this topic. A cumbersome group processes can threaten trust. Tokenistic commitments, often people working intersectorally will be enthusiastic at the beginning, then they eventually just send the intern to go, or they change the people going. It's not a real commitment to co-designing and co-developing a new way of addressing common problems or challenges. And the failure to meet or adapt commitments is also threatens trust. Moving on to California, I'm going to focus in on, I mentioned earlier how they were started, so I'm really going to focus in on some work they've done around housing, walking, safety, neighborhoods, those kind of issues. So they started off with looking at what kind of goals could we sign up to across multiple sectors. And these are the kind of things which they came up with. And these, if you look at them, you say, oh, that's not a health agenda, is it? No, it's the social conditions of health agenda. But it doesn't have to be called a health agenda, because these are all important things for health, but most important, they're important for others. So with these aspirational goals, when they brought the different sectors together, they were able to create the start of trust and the start of working together. At that stage, they had seen that housing and health was a very important issue. This is a quotation that they took from, which illustrates the importance of social conditions for health, but the difference in that it's not seen often as there's not seen a clear link between the conditions we're living in and the health. And one of their leaders was saying there's a magical vaccine out there that would improve the physical and mental health of many Americans, ease pressure on a wobbly healthcare system, and in the long term, help to put a dent in the nation's troubling budget deficit. The vaccine is called safe, stable, and affordable housing. And And so after defining the broad aspirational goals for the population in California with the group, they then went to look on to discuss why housing is critical as a determinant of health, and brought together the evidence on affordable housing, stability in housing, accessible housing, which also has to do with disabilities and also accessibility to work, long travel time, etc., which is also measured under location efficiency. So in the public health literature on housing, you will find these aspects linked to different health outcomes. They then also brought in the equity lens. They showed how the negative health impacts then occur in low-income households disproportionately, reinforcing a cycle of poverty and disadvantage. They showed vulnerability and how this affected children, elderly, and pregnant women, and brought in the literature, which I mentioned in my first slide, about this cumulative effect over the life course from childhood to schooling through to adult workinghood and so on, all the effects that affect our prospects to live a long and healthy life, hopefully. They then also really looked at what was the context for housing in California, the style of American living, where they live a lot far away from the places of work, the need to have lots of transport networks and freeways and so on. And then the growing body of evidence linking the traffic really and the traffic problems, while the housing policy was really focusing around not linking really to the distance that people would have to travel, the fact that people have to use highways more, and that the dense use of cars would lead to this list of health outcomes. They then, in 2011, had a task force which issued these recommendations to promote sustainable development through smart housing siting, develop recommended processes for balancing public health objectives affecting air quality, and the siting of the transit-oriented development, so where the suburb or where the housing is located relative to the freeways, and then identifying needs for research. They convened the stakeholders to discuss this, and they clarified existing guidance on the siting of new housing and new development. And so they really worked a lot with the urban planners and the rules around siting. I won't go into the rest because I am running a bit of time, but they also took, I'll leave these slides with you, but they also took the leadership qualities that we discussed in 2010 with the experts who came together, and they unpicked how in each phase of their work on housing, they had used these leadership qualities and what they had done to demonstrate these leadership qualities. So in summary, how do we communicate? If you're convinced and you want to do health in all policies, how do you communicate it? You don't have to say to the other person, I'm doing health in all policies. You can say, I'm working on sustainability, I'm working on well-being, etc. So you don't have to use the term. You can say it's about it's quality improvement, the quality of governance, the public policy quality improvement, collaboration, and integration for sustainability. And then I suppose I'm going to jump to the bottom. What are the main barriers that you have to confront if you decide you want to do it? Well, we have the siloed structures, so we have to respect that, but at the same time find coordination mechanisms that work across them. We need the capacity to coordinate activity beyond the silos, which is a barrier. Often people don't know how to work across silos. We don't have the knowledge of why and how the policies in other sectors link to health. And then behind it, we also have political, economic interests, which don't think that working on public health is that important. So with that, I hope you think it's important, and thank you for your time. Thank you.